Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
One of the principal objectives of the four-handed dentistry concept is to provide the operator with relatively comfortable and convenient access to all areas of the oral cavity. However, the quality of access and visibility is influenced significantly by the area of the mouth to be treated, the type of treatment to be rendered, the anatomy of the patient, and the instrumentation required during treatment. Despite these variables, guidelines have been established to assist the dentist in achieving relatively comfortable and convenient access. These guidelines are rather specific and offer suggestions on key factors such as operator-patient positioning, establishing positive finger rests, achieving adequate retraction of soft tissue, and controlling oral fluids. For purposes of discussion, the dental arches will be divided into 6 segments, since the operator-patient position varies with the specific segment to be treated. In the maxillary arch, these are the left posterior segment, the anterior segment, and the right posterior segment. The mandibular arch is divided similarly as follows: the left posterior segment, the anterior segment, and the right posterior segment. In addition, there are 3 approaches possible within each segment. These approaches are the buccal or labial approach, the occlusal or incisal approach, and the lingual or palatal approach. The approach to be used will determine in part the operator-patient position, the retraction to be used, and the location of finger rest. In addition, the approach will dictate the position of the oral evacuator. Illumination of the oral cavity is an important aspect of visibility. Generally speaking, high light angles are required for mandibular areas, and low light angles are used for maxillary areas. Let's look at the guidelines for gaining access and the visibility necessary for working in the 6 segments of the oral cavity using the 3 approaches just described. Direct vision is recommended for the buccal approach to the maxillary left posterior segment. Access to this segment using the buccal approach is usually excellent when treating either the bicuspid teeth or the first molar. The second and third molars are less convenient to treat due to interference by buccal soft tissues or the coronoid process of the mandible. However, access can be improved in the more posterior area by having the patient close slightly, which moves the coronoid process posteriorly and provides more slack in the cheek for easier retraction. Access and comfort for the operator is enhanced by placing the patient in supine position. The operator can then work from the 10 o'clock position. Final adjustment to improve access is accomplished by turning the patient's head considerably toward the operator and slightly elevating the chin. Once the operator and the patient are in position, retraction is accomplished with the operator's left index finger. Finger rests are established on the incisal edges of the anterior teeth, and the evacuator tip is placed along the occlusal surfaces near the tooth being treated, with the opening directed toward the handpiece. Visibility is accomplished by using indirect vision while working in the maxillary left posterior segment using an occlusal approach. The mirror has to be positioned as far from the operative site as practical and angled so that it gives the operator a lateral view of the handpiece. The operator can work comfortably from the 11 o'clock position with the patient in supine position. The final adjustment in gaining access to the patient is accomplished by having the patient's head turned slightly toward the operator. Access to the operative site is achieved by having the chairside assistant retract the cheek with the tip of the evacuator. The tip opening should be placed just distal to the tooth being treated and oriented so that the opening is parallel with the buccal surfaces of the teeth. Whenever possible, the evacuator tip should be placed behind the mirror to allow more freedom of movement of the mirror for the operator. However, this is not always possible when the more posterior teeth are being treated. The surface of the mirror is kept free of water drops that can obstruct vision by having the assistant maintain a stream of air across the mirror surface when the handpiece is being used. Finger rests are established on the occlusal surfaces of the right maxillary incisors or bicuspid teeth. Direct vision is used when a lingual approach is used in the maxillary left posterior segment. Once the preparation is underway, then the fine detail of the cavity can be examined using the mouth mirror whenever necessary. Once again, the patient is supine with the operator working from the 9 o'clock position. In most cases, access is improved by having the patient's head turned toward the assistant as needed. Stability for the operator is accomplished by establishing a finger rest on top of the operator's left index finger, which is placed over the occlusal surfaces of the maxillary right bicuspid teeth. The operator's left index finger not only provides a favorable finger rest, but also retracts the right cheek for improved visibility. The left cheek is retracted by the chairside assistant using the evacuator tip placed at the buccal surface of the tooth being treated. The opening of the tip is directed toward the handpiece with half of the opening placed below the occlusal surface of the tooth being treated. Regardless of which approach is required, the maxillary left posterior segment can be treated successfully using the guidelines just presented. The labial approach to the maxillary anterior segment is the most convenient of all the approaches to the oral cavity. Excellent access is available to the operator and direct vision can be used. With the patient supine, the operator can work very comfortably from the 11 or 12 o'clock positions. The patient's head is turned slightly toward the operator as needed to improve access. Retraction is accomplished with the operator's left index finger. A stable finger rest can be established on either the incisal edges of the right anterior teeth or the occlusal surfaces of the maxillary right bicuspids, depending on the area being treated. The evacuator tip is placed to the lingual of the tooth being treated, with 1/2 of the opening placed beyond the incisal edge. This approach is often required for crown preparations and Class 4 restorations. Both direct or indirect vision can be used interchangeably as needed depending on the task to be performed. Generally, the operator has convenient access to the operative field from the 11 o'clock position while the patient is supine. Refinements in achieving access can be obtained by having the patient elevate the chin and turn toward the operator as needed. The upper lip is retracted with the operator's left index finger. Again, finger rests are established on either the incisal edges of the adjacent anterior teeth or the occlusal surfaces of the maxillary right bicuspid teeth. The evacuator tip is placed near the tooth being prepared with the opening toward the handpiece. It is generally located on the lingual aspect. However, it is often repositioned on the labial aspect if the water spray tends to escape over the patient's upper lip. The chairside assistant should monitor fluid accumulation in the patient's mouth and remove it whenever the operator pauses during the preparation. Indirect vision is used for the lingual approach to the maxillary anterior segment. The mirror should be held as far from the preparation as possible to minimize the accumulation of water drops on the mirror surface. Comfortable access can be obtained with the operator in the 11 o'clock position with the patient supine. The patient's chin should be elevated slightly and the head turned toward the operator as needed to improve access. Retraction can be accomplished with the assistant's left index finger or with the tip of the oral evacuator. The oral evacuator is used in cases where it is necessary for the assistant to use her left hand to operate the air-water syringe to keep the mirror surface clear of debris. Finger rests are established on either the incisal edges of the adjacent anterior teeth or on the occlusal surfaces of the maxillary right bicuspid teeth. The oral evacuator is used as a retractor and to control the water spray from the handpiece. It is placed to the labial of the tooth being treated with the opening directed toward the head of the handpiece. Excellent access and visibility are possible in the maxillary anterior segment using these guidelines regardless of which approach is used. Like the maxillary anterior segment, access is excellent for the more anterior teeth in the maxillary right posterior segment when a buccal approach is used. Direct vision is possible while treating teeth in this segment using a buccal approach. With the patient supine, the operator can obtain convenient access from the 9 o'clock position. Final adjustment in establishing access can be accomplished by having the patient turn slightly toward the dental assistant. The operator's left index finger is used to retract the patient's cheek. A stable finger rest can then be established on the left index finger. The evacuator tip is placed along the lingual surface of the tooth being treated with half of the tip opening beyond the occlusal surface. The occlusal approach to this segment requires the use of indirect vision in most instances. The patient is supine with the operator working from the 11 o'clock position. The patient's head should be turned slightly toward the operator with slight chin elevation. Retraction is generally the most common difficulty encountered while working in this segment. Most operators have solved this inconvenience by using the third finger of the right hand to establish a rest against the buccal surfaces of the posterior teeth. The finger also serves to retract the cheek at the same time. A cotton roll placed in the mucobuccal fold aids in the retraction function. The evacuator tip is placed along the lingual surfaces of the posterior teeth with the opening parallel to the surfaces. Due to the supine position of the patient, it is advantageous to place the tip distal to the tooth being treated. Whenever possible, the mirror should be located anterior to the tip to permit freedom of movement of the mirror. Direct vision is recommended while using a lingual approach to the maxillary right posterior segment. However, close inspection of the cavity preparation can be accomplished using indirect vision. The operator can work from the 9 o'clock position with the patient supine. The patient's head must be turned considerably toward the operator, and in most cases the chin is elevated to the maximum. The operator's left index finger is used for the retraction of the cheek. The retraction finger is also used as a finger rest for the right hand. The evacuator tip is placed along the lingual surface 1 to 2 teeth distal of the tooth being prepared. In the most posterior teeth, intermittent evacuation is recommended as fluid accumulates. Although the right posterior segment is somewhat less accessible than the other two maxillary segments, the supine patient position still provides a relatively comfortable approach to treating this area of the oral cavity. Direct vision is used while operating the handpiece using a buccal approach. However, close inspection of the detail of the preparation can be done using indirect vision as the preparation sequence progresses. The operator can work comfortably from the 11 o'clock position with the patient supine. The patient's head is turned toward the operator as needed to improve visibility. Retraction of the patient's left cheek can be accomplished with either the operator's left index finger or with a mouth mirror. The labial surfaces of the anterior teeth provide an excellent finger rest for the operator's right hand. The evacuator tip generally is placed along the buccal aspect of the teeth 1 to 2 teeth posterior to the tooth being treated. The opening of the tip is directed toward the handpiece. In the most posterior areas, intermittent evacuation may be used as fluids accumulate. Direct vision is used predominantly during the preparation of teeth using the occlusal approach. However, indirect vision is frequently used for close inspection of the prepared cavity. The operator can work comfortably from the 11 o'clock position. The patient is positioned in either a supine fashion or angled slightly upward for improved visibility. The patient's head should be turned slightly toward the operator with chin elevation as needed to improve access. Retraction of the left cheek can be accomplished with the evacuator tip and the mouth mirror. The tongue is retracted with a hygoformic saliva ejector. This device is adjustable and provides custom-designed retraction that is not possible with a sphincter. A finger rest can be established on the labial surfaces of the mandibular right anterior teeth. The evacuator tip opening is placed parallel to the buccal surface of the tooth posterior to the tooth being treated. The edge of the opening should be at the height of the occlusal plane. Direct vision is used when the handpiece is in use from a lingual approach. Close inspection of the details of the preparation can be accomplished using indirect vision as required. The dental chair is positioned so that the chair base is lowered completely and the chair back is raised until the patient's oral cavity is at the operator's elbow height. The operator can gain access from the 9 o'clock position. The patient's head is turned slightly toward the dental assistant to improve visibility for the operator. The cheek can be retracted with the evacuator tip and the assistant's left index finger when necessary. The tongue is retracted by the operator with the mouth mirror. A finger rest can be established on the mandibular anterior teeth. The evacuator tip opening is placed parallel to the buccal surface of the tooth being treated. One half of the tip opening should extend above the occlusal surface of the tooth. Access is somewhat impaired in mandibular areas due to the presence of the tongue. Proper retraction using the hands of the dental assistant and retractors can overcome this interference. Most operators appreciate the advantage of using direct vision whenever possible. Such is the case when treatment is carried out in the mandibular anterior segment using either the labial or incisal approaches. With the patient supine, the operator can work comfortably from either the 11 or 12 o'clock positions. The patient's head is turned toward the operator as needed to improve access. A slight chin elevation is usually helpful in improving visibility. The lower lip can be retracted by the operator with the thumb and index finger of the left hand. A 2x2 gauze is used to add control when the lip is grasped. Finger rests can be established on the facial surfaces of the mandibular right cuspid or premolar teeth, depending on the operative site. The evacuator tip is placed lingual to the tooth being treated with one half of the opening above the incisal edge. Direct vision is used predominantly with an incisal approach to the mandibular anterior segment. However, supplemental use of indirect vision is often helpful during the preparation of the lingual aspect of a tooth. The 11 o'clock position is the position of choice for the operator. The patient is placed in the supine position. The incisal approach is used most often for crown preparations in the mandibular anterior segment. Access and visibility can be improved by readjusting the patient's head position as needed during the various phases of preparation. Generally, slight chin elevation with the patient's head turned toward the operator is most helpful. If direct vision is used, then the operator can retract the lower lip using a 2x2 gauze sponge between the thumb and index finger of the left hand. The dental assistant can retract the lower lip with her left index finger when indirect vision is used. A finger rest can be established on the buccal surfaces of the mandibular right premolar teeth. The evacuator tip is placed labial to the tooth being treated with the opening oriented toward the head of the handpiece. Indirect vision is the usual method of choice for achieving visibility when the lingual approach is used in the mandibular anterior segment. The operator works from the 11 o'clock position with the patient supine or raised very slightly above supine. The patient's head is turned slightly toward the operator with little or no chin elevation. Retraction of the lower lip is accomplished with the index finger of the dental assistant's left hand. A finger rest can be established on the buccal right premolar teeth. The evacuator tip is placed labial to the tooth with the opening toward the handpiece. Although the mandibular anterior segment is usually convenient to reach, access varies with the labial-lingual position of the teeth and the patient's ability to open widely, especially when the lingual approach is used. The buccal approach to the mandibular right posterior segment can be accomplished using direct vision. The operator has comfortable access to this area from the 9 o'clock position. The patient's chair is lowered as far as possible, and the chair back is raised until the patient's oral cavity is at the elbow height of the operator. The patient's head is turned slightly toward the dental assistant. Retraction can be accomplished with the operator's left index finger in the bicuspid region, whereas a mouth mirror is often more helpful in the more posterior areas because it is thinner and allows more space for the head of the handpiece. A finger rest can be established on the labial surfaces of the mandibular anterior teeth. The evacuator tip is placed lingual to the tooth being treated with 1/2 of the opening beyond the occlusal surface. Direct vision is used for the most part during cavity preparation. Indirect vision can be used as a supplemental approach to visibility during inspection of the fine detail of a preparation. The operator generally works from the 9 o'clock position. The chair base is lowered completely and the patient's chair back is raised to position the oral cavity at the height of the elbow of the operator. The patient's head is turned slightly toward the operator with the chin lowered slightly. The patient's cheek can be retracted with the operator's left index finger. The tongue is retracted with a hygoformic or with the assistant's mouth mirror. The operator's left index finger can be used as a finger rest for the right hand. This allows the handle portion of the handpiece to be positioned toward the operator. This position provides for favorable illumination of the operative field and control for the operator. The evacuator tip opening is placed parallel to the lingual aspect of the teeth and slightly distal to the tooth being treated. The lingual approach to the mandibular right posterior segment is one of the most difficult areas to treat from both a visibility and access standpoint. The location of the lingual surfaces relative to the operator prevents a good direct angle of view. The presence of the tongue reduces access, especially in the most posterior areas, and tends to inhibit the use of indirect vision. Generally, direct vision is the method of choice during the operation of the handpiece, supplemented by indirect vision to inspect the fine detail of the preparation. The operator works from the 9 o'clock position. The dental chair is lowered to the maximum, and the chair back is raised until the patient's oral cavity is located at the elbow height of the operator. The patient's head is turned considerably toward the operator to gain as much direct vision and access as possible. The cheek is retracted with the operator's left index finger, and the tongue can be retracted with a mouth mirror by the chairside assistant. A finger rest can be established on the labial surfaces of the mandibular anterior teeth or on the buccal surfaces of the mandibular left premolar teeth. Due to the limited space available when the lingual approach is used, intermittent evacuation is recommended as fluids accumulate. In addition, once the preparation is opened, it is often helpful to complete the preparation with a conventional speed handpiece. This eliminates the hindrance of the water coolant and offers the operator greater control. Due to the presence of the tongue, the mandibular posterior segments tend to be more difficult to treat. However, through the use of effective retraction by both the operator and the chairside assistant, access and visibility can be achieved. Regardless of the area to be treated or the approach to be used, the dental assistant will work from the 3 o'clock position. Modifications in the height of the assistant's stool may be required from time to time. These guidelines require a maximum effort by both the operator and the assistant to work as a well-coordinated team in order to accomplish comfortable and convenient four-handed dentistry. This effort will result in a more enjoyable and productive method of practicing dentistry.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.